demographic data. The name of the patient is not indicated in the case study. That's why we label him as patient C. The patient is male and he is currently 60 years of age. He is known as white people with no occupation as indicated. Under his chief of complaint, he is suffering on acute onset shortness of breath.
History of present illness. Symptoms began approximately 2 days before and had progressively worsened with no associated, aggravating, or relieving factors noted. He had similar symptoms approximately 1 year ago with an acute, chronic obstructive pulmonary disease, exacerbation requiring hospitalization. He does report difficulty breathing at rest, forgetfulness, mild fatigue, feeling chilled requiring blankets, increased urinary frequency, incontinence, and swelling in his bilateral lower extremities that is new onset and worsening. Subsequently, he has not ambulated from bed for several days except to use the restroom due to feeling weak, fatigued, and short of breath.
Past medical history. He denies fever, chills, cough, wheezing, sputum production, chest pain, palpitations, pressure, abdominal pain, abdominal distension, nausea, vomiting, and diarrhea. Past medical history is significant for coronary artery disease, myocardial infarction, COPD, hypertension, hyperlipidemia, hypothyroidism, diabetes mellitus, peripheral vascular disease, tobacco usage, and obesity. Past surgical history is significant for an appendectomy, cardiac catheterization with stent placement, and nephrectomy.
Personal or social history. There are no known ill contacts at home. His family history includes significant heart disease and prostate malignancy in his father. Social history is positive for smoking tobacco used at 35 years. He quit smoking 2 years ago due to increasing shortness of breath. He denies all alcohol and illegal drug use, and there are no known foods, drugs, or environmental allergies.
Review of systems. Physical exam. Initial physical exam reveals temperature 97.3 Fahrenheit, heart rate 74 BPM, respiratory rate 24, blood pressure 104/54, BMI 40.2, and oxygen saturation 90% on room air. Constitutional. Extremely obese, acute ill-appearing male, well-developed and well-nourished with BiPAP in place, lying on a hospital stretcher under 3 blankets.
The HEENT. For the head, normocephalic and automatic. For the mouth, moist mucous membranes, macroglossia. For the eyes, conjunctiva and EOM are normal. Pupils are equal, round, and reactive to light. No scleral icterus. Bilateral periorbital edema are present. For the neck supple, no JVD present, no masses or surgical scarring. And for the throat, patent and moist.
Cardiovascular. Normal rate, regular rhythm, and normal heart sound with no murmur. 2+ pitting edema, bilateral lower extremities, and strong pulses in all 4 extremities. Pulmonary or chest. No respiratory status distress at this time. Tachypnea present. Wheezing noted. Bilateral rhonchi. Decreased air movement bilaterally. Patient barely able to finish a full sentence due to shortness of breath. Abdominal. Soft. Obese. Bowel sounds are normal. No distension and no tenderness. Skin. Skin is very dry. Neurologic. Alert, awake, able to protect her airway, moving all extremities. No sensation losses.
This presentation is presented by Ash Joshua Labasao, Cyril Catherine Farello, Jump I'm Renew, Mary Ann Flores, Oliver Abig, Rufino Salvador, and yours truly, Romina Eloisa Tudakay. Thank you for watching!